Good morning, everyone. My name is Jim Rodriguez, and I'm the Senior Director of Clinical Initiatives at the McSilver Institute and the Community Technical Assistance Center of New York. And I'd like to welcome you to today's training on narrative enhancement cognitive therapy. Before we get started, I wanted to take a moment to orient everyone. We're going to jump right in because there's a lot of material to cover. But I want to sort of orient folks to a few things about today's event. Please note that as you are joining the event, you're in mute, and you'll be placed in mute to avoid any background noise that can happen during the course of the training. If you come across any technical issues, please chat in to our host today, Connor. She'll be able to try to assist you with any problems you might be having. You will have the opportunity to unmute yourself during Q&A periods today, but you're also encouraged to submit questions throughout the course of the training, and you can submit your questions in the chat. And please feel free to do that as often, and we'll bring those questions back to our presenter, Dr. Phil Llanos. We would appreciate it, though, if you could take a moment to fill out a brief survey. Our coordinator, Connor, is going to put in the chat a brief survey that will appear, and we'd ask you to complete it. We're actually going to ask folks to take a minute or two to complete that survey. This training is normally a longer training, and it's the first time, I believe, Dr. Llanos is going to be doing this virtually, but we also want to get some good information and feedback from you all. So if you can take a moment, a minute or two to complete the pre-survey, and we're also going to come back at the end and ask you to complete a survey at the end as well to give us as much feedback. So what we're going to do is we're going to go silent for a moment and give folks an opportunity to complete that survey, and then we'll continue in 2 minutes. For those folks who are joining us as we speak, we're just giving folks a minute or two to complete a survey. The survey link is in the chat, so please take a moment to complete that survey for us. We're going to ask folks to complete the survey at the end of today's training as well. I see folks are joining as we speak, so for folks who are joining us, what we're doing right now is having folks complete a survey. The link to the survey is in the chat. Please take a moment to complete that survey before we move on. Good morning, folks. Again, I see people joining us again as we speak. So those folks who may be joining us a couple of seconds late, please note that what we're doing right now is having folks complete a survey. The survey is in the chat. The link to the survey is in the chat, so please open up that link and complete the survey. We're looking at feedback on today's training, as much feedback as we can get. Thank you all for joining. Okay, thank you, everyone. As I already mentioned, again, we're just asking folks to complete that survey. Thank you all who had a chance to do that. And then just a couple of other reminders. The recording for today's presentation, the presentation slides, And the materials for narrative enhancement cognitive therapy will be posted on our website. Oh, excuse me, I should say, if you've been invited to this training or signed up for this training, you should have received an email with the materials, including the facilitator guide for today's training. If you did not, please note and look in the chat, and Connor will put the link to the page in the chat so that you can access those materials, which Dr. Llanos will be referencing throughout today's training. So please take a look at that. And then all of the materials will be posted on our website. The slides, the recording of this training as well will be on the CTAC website within 2 to 3 business days. And then just really quick, I want to mention that there are CEs available for this training. This is some information about the 2 contact hours of CEs for LMSWs, LCSWs, and licensed mental health counselors. You must be present for at least 75% of the offering. You must attend using your own unique Zoom link, and you must attend this offering on your computer. Your attendance cannot be tracked if you attend only by phone. So just a few reminders if you're interested in CE, and then CE information will be emailed to you in about a week, so you can go ahead and get those CEs, and you'll get an email with information about how to get those CEs. And so with all that said, I'd like to introduce our speaker today. So we're very excited to have with us today Dr. Phil Llanos. Dr. Llanos is a licensed clinical psychologist and a professor in the psychology department at John Jay College. He currently serves as the director of clinical training for the clinical psychology PhD program at John Jay and at the Graduate Center. He's a internationally recognized researcher on mental health stigma. He's an associate editor for the journal Stigma and Health and the author of Written Off Mental Health Stigma and the Loss of Human Potential. He's also the co-developer of the intervention that we're going to be covering today, narrative enhancement cognitive therapy. It's a group-based treatment which addresses the effects of self-stigma among people with mental illness. In addition to researching the causes and consequences of mental health stigma, he has also studied the effects of PTSD as well as the psychosocial predictors of community participation among people with severe mental illness. Phil's an exceptional researcher and a scholar, and he comes to this work from a very personal space. So with all that said, I'd like to thank you all for joining us today, and I'll pass it along to Phil.
Thank you, Jim. Great honor to be presenting to all of you today. Hope that you're able to hear me well. So just a little bit about me. I just wanted to share before I get into it is that I grew up on grounds of a state psychiatric hospital on Wards Island here in New York City. I'm a clinical psychologist and I work on a assertive community treatment team part-time for the agency Services to Underserved. My main job is that I'm a psychology professor at John Jay. And I do research on stigma, and I've been doing that for the past 15, 20 years. And I also am an advocate for the lived experience movement, and I'm currently involved with City Voices and with the Institute for the Development of Human Arts. So I do want to acknowledge my collaborators in this work. So David Rowe and Paul Lysacker and I are the ones who work together to develop NECT. And NIMH funded the development of it and meant much of the research that we'll talk about. And I also want to thank the master's and doctoral students who helped with the role play videos that you'll be seeing that are allowing me to do this in a more compacted amount of time. So you'll be seeing all of them, and they really help a lot. So because this is a shorter presentation, I'm not able to go into documenting that stigma is a persistent reality in society. So I'm going straight to this information on how does it affect people who've been diagnosed. And so what I want to note here is that people with mental health conditions are aware of stigma and largely anticipate discrimination. And so this is supported by large amounts of research, and also that they believe that most people hold stigmatizing views and would reject a person with mental illness as a friend, colleague, neighbor, etc. So then the question is, how does this affect people? And Pat Corrigan and Amy Watson developed a model where they basically predicted there would be 3 different possible responses. The first would be indifference, where the person doesn't see stigma as relating to them. They don't identify as a member of the group. The second is righteous anger, where the person sees it as unjust and something to stand up against. And the third is self-stigma, which is what we're going to focus on now. And when we're thinking about self-stigma, this is a situation where the person identifies as a member of the group. They identify as somebody who has a mental illness or is somebody who is seen as part of that category. And they believe that stereotypes are legitimate. And what this means is that they'll believe that they are true about them. And so when we're thinking about self-stigma, we should also be thinking about identity. And what this means is that the identity of having a mental illness takes over or supersedes the other identity categories that the person is bringing to the table. And this can be based on their ethnic background, personal accomplishments, talents that they have, and other characteristics. And so this has been something that's been researched now for roughly 20 years after the development of the internalized stigma of mental illness scale. And there's been a lot of research been done. And what we find is that approximately a third of people with serious mental illnesses show evidence of elevated, or what we could say clinically significant, internalized stigma, with the highest prevalence among people diagnosed with schizophrenia. But we also see high prevalences of it among people with bipolar disorder, PTSD, borderline personality disorder. So what we can think of is that roughly a third of the people that we are working with have this very clinically significant need for something to address this. I want to note that my colleagues and I have focused on the effects of self-stigma, and we came up with this illness identity model where we believe that it would have these pervasive effects on the recovery process. So just to quickly review that, we believe that it would have a direct impact on hope and self-esteem, diminishing both. And this would lead to sort of a chain reaction where suicide risk would be increased. People would be engaging in more avoidant coping and less engaged in services. They would be more socially avoidant and isolated. And this would have an indirect effect on their work outcomes and on the severity of their psychiatric symptoms. And this is something that we've done a bunch of research on, but there's also been meta-analyses that support a lot of these relationships. So this more recent one by Del Rosal et al. Is from 2021, and it focused on studies conducted since 2010. And they found these significant pooled relationships across studies on self-esteem, subjective quality of life, hope, depressive symptoms, and subjective recovery. And we did our own review of studies that touched on aspects of this illness identity model that was published in 2020. And we looked at studies that had been done across 43 countries, 23,000 participants, and a range of different clinical conditions, but mostly people with severe mental illness or schizophrenia spectrum disorders. And this just shows countries that studies had been done in that we included in the review. And what we found is that by and large, they supported many of the predictions we had for this illness identity model, that internalized stigma has this pervasive effect on a range of outcomes, not just self-esteem, but including things like treatment adherence, social interaction, employment, and symptom severity. So what all of this leads to is just the kind of the justification for an intervention that addresses this. And so what we see is that anticipated discrimination is the norm among people with mental illness. Elevated self-stigma is common and experienced by a third, approximately, of people with mental illness. And self-stigma has this pervasive impact on a range of outcomes that are related to recovery. And this seems to be something that exists regardless of age, diagnosis, or cultural context, since we've found these patterns internationally. So this leads to our development of this intervention. And so in 2006 and 2007, David Rowe and I had a bunch of conversations about our interest in doing something to address this area. And David had already known Paul, and he helped loop him in. And what we decided was we wanted to apply for funding to develop an intervention. And we were fortunate enough to get that. And we developed something that we have ended up calling narrative enhancement and cognitive therapy. I don't think it's a great name. We just chose it because it could create an acronym. But it does capture some of the elements of the intervention, which is that it includes psychoeducation focused on, correcting myth-based views about mental illness and recovery, cognitive restructuring, teaching people skills to challenge negative thoughts about the self that are impacted by self-stigma, and then storytelling exercises, which is the narrative enhancement part, that are geared toward helping people integrate empowering themes into their life stories. When we developed it, we thought that this was something that was going to take a while to address, and that's why we developed this 20-session idea of it, that it would be a longer psychosocial intervention than maybe a lot of psychotherapy is, where we see 12 to 16 weeks being kind of the standard. And I understand that that's an issue around it, given that 20-week intervention is a lot, and there are some shorter versions that have been developed that I can mention. And so I do want to acknowledge the passing of Paul Lysacker at this point. So he passed away this summer, suddenly, unexpectedly, and it's really sad that he hasn't been able to participate in some of these initiatives that we're doing now that I'm going to talk about in a minute. And so he's made an enormous contribution to research, especially on with his development of Merit, which is an individual psychotherapy approach that he's developed for people with psychosis. But really a great guy, wonderful clinician, a great mentor to a lot of people. So this is what the manual looks like for our original English language version. And I'm told that you've received this. I've just created a website where I've actually also posted these, and I can mention that to you as well. So at this point, there have been 5 controlled studies on NECT that I know of, and the first was the small RCT that we did when we had our developmental intervention grant from NIMH, and it only had a small sample size, so it was what we would say was underpowered to detect any effects. The second was a quasi-experimental study done in Israel by David Rowe, and this was basically, there were 2 different sites, and one implemented NECT, the other didn't, and they compared changes in self-stigma across those 2. Then there was a larger randomized controlled trial conducted in Gothenburg, Sweden, after I trained folks there. We also did a larger RCT in the US around the same time. And most recently, there was a moderate-sized randomized controlled trial conducted in Taiwan with a Mandarin version of it. So basically, what we found is consistent evidence for positive effects on self-stigma and self-esteem. And because these RCTs were done by independent groups, we can say that it kind of reaches the threshold of being considered an evidence-based practice at this point with the 4 RCTs that have been done. These are locations around the world that we know of that have implemented NECT. Again, not everybody tells me, but we know that These are places where people have implemented and have been in touch with us. And these are the languages that we know of that it's been translated into, obviously English, but most recently Urdu. I mentioned Mandarin. In Israel, they've translated into Hebrew and Russian. There's a Spanish version that I have that can also be made available to anybody who wants to use it. And I just want to note that we have been doing this just by coincidence. We initiated something we're calling NECT Global, where we're meeting with people from places around the world that are implementing it. And so this past Monday, we had our first meeting at 7:30 a.m. Eastern Standard Time, so very early, but that's part of what you do when you're trying to address time differences around the world. And so I'm just putting in the chat the link to the recording of the first NECT Global meeting, which is on YouTube. And the second meeting is to be this coming Monday, also at 7:30 a.m. And we're going to have presentations from researchers from France, Netherlands, Hong Kong, and Germany. And the website, I did make it live, but it's very much in its infancy, so needs a lot of work. So the conclusions we can have about NECT as a intervention approach right now is that it is effective at reducing self-stigma with a moderate effect size, which means that it's not just a small effect that you can only see if you have a very large sample. It also generally, we find that improves self-esteem. It's more effective when we're not comparing it to people who are getting a lot of services. This is what we found in our US study. And it appears to be robust to translation and cultural context. So these 4 places where it's been studied are all very different. So as far as we know, it seems like it works regardless of where you do it. So what I'm going to move into now is talking about the manual and what goes into it, and also this idea of how it can be done with fidelity, or how it kind of can conform to the ideals by which it was developed. So again, you should have both of these, but we have these 2 versions of the manual. And the first one is the participants workbook, and then there's the facilitator's guide. And the idea is that they have the same number of pages, and the facilitator's guide just has some extra text in it that is to draw the facilitator's attention to things that they should be thinking or doing as they're leading people through the workbook. But the idea is that people have their workbooks, they're expected to write in them, and we're supposed to go through it step by step. So when we developed the facilitator's guide, it came from this idea that we knew that most treatment manuals had like this long introduction section, and then it had a bunch of handouts. And in our experience, nobody ever read that introduction. So we wanted to put the things that we wanted people to think about or know about where they would see them, right where all the handouts were. So that's why we developed the facilitator's guide version, kind of this idea that it's sort of like the teacher's edition of a textbook or something. And it's 56 pages long in its original version. And so that comes down to about 3 to 4 pages per meeting. But it does vary depending on which part you're doing. So we have introduction is supposed to be the first 2 sessions, then stigma education or psychoeducation is the next 3. Cognitive restructuring is supposed to go on for 7 sessions, narrative enhancement for the next 7, and then summing up is the last meeting. So obviously we're putting most of our attention to cognitive restructuring and narrative enhancement, and perhaps there's some room for shortening the number of sessions devoted to those areas, but I do want to emphasize that they are the most important parts of this. So I want to emphasize our approach is, and you'll see this in the recorded role plays, is that we have straightforward educational passages and exercises. People are supposed to read them. We ask that they be read out loud, but we don't just want them to be read. We want them to be processed and explored and reflected on. And so we see this as the way that people take in material and they decide if it applies to them or not, right? So we don't expect it to work for people or resonate unless they reflect on it and get to talk about how, or if at all, they think it relates to them. We want people to be, doing the exercises and if comfortable reading their responses as well. And you'll see that also in the role plays. And I also want to note that we want people to implement the material in their daily lives, but we don't have official homework like a lot of interventions do, but we encourage people to take it home and try it out and talk about how it relates to them in the group. We think that this intervention works from all of its elements. We think all of its elements have an impact. So we believe that psychoeducation can reduce stereotype endorsement, which is a big part of self-stigma. People will learn that these are inaccurate views. Then we think that cognitive restructuring can be very helpful for helping people deal with those moment-to-moment negative thoughts that are deeply ingrained and related to self-stigma and low self-esteem and hopelessness. And so we want people to learn a coping skill for dealing with these negative thoughts as they come up in their lives. And we hope that this can reduce stigma-related social anxiety and depressed mood. The narrative enhancement part is supposed to really kind of go deeper and give people a chance to integrate this into the stories they tell about themselves. And at times, we've seen that this can lead to some very broad, insightful realizations that can really increase motivation to change. And so we've seen this. I experienced this in the first group that I did when we were piloting it. And there was something similar that was described in one of the early groups that was done in Sweden as well. So we don't expect that to happen every time, but there are times when people will have these kind of aha realizations as a result of the narrative enhancement component. So thinking about a typical group session in a program that has, group scheduled, we think of this as typically an hour. So I understand some places might be a little shorter, it might be a little longer. So what I'm presenting has some flexibility, but based on this idea of it lasting an hour, the first 5 to 10 minutes would be review of the previous meeting, greeting people who were absent, encouraging them to review anything that they missed, seeing if people who were present can summarize for them, and reminding people of where we were previously and where we're going today. And that's the agenda setting sort of component of what we do. And then in the middle, which is that middle 40 to 45 minutes, you work on those 2 to 3 pages of material. You know where you are, and you encourage people to volunteer to read 2 to 3 sentence chunks of text. And then you do that asking people for reactions, elaborations, anything that they're confused about, explaining it. And then you encourage people to do the written exercises in the workbook. And if they're comfortable volunteering to discuss their responses and then reflecting on that, and maybe there's some common themes. We want groups to have a facilitator and a co-facilitator if possible. And so the co-facilitator can jump in and help people with things like literacy issues, if they have difficulty writing, or they can also maybe be listening for common themes and taking in some of that type of work in this part of the group. At the end, there should be some time summarizing what's been learned and discussed. And then that can be that encouragement to try what we've been learning outside the group, which again, we've described as not official homework, but encouragement to bring things into your life outside the group. As I mentioned, ideally, we have 2 group facilitators, a facilitator and a co-facilitator. And so what we encourage people to do is kind of develop a pattern where you plan out who's going to be mostly responsible for things. So we can think about it as there being a primary and a secondary. And so the primary facilitator is going to be responsible for making sure everybody's workbooks are there, having attendance sheets, kind of asking people to read and maybe being able to pick who can go of those who are volunteering. While the secondary facilitator could be the person making those more thoughtful comments, helping somebody who's emotionally distressed, who might need to kind of be spoken to individually, or helping people with literacy difficulties. And so this leads into our fidelity criteria that I think also kind of speak to some of our principles and values about how these groups should go. So first of all, if you haven't heard about the term fidelity, it's a term that's used with regard to psychosocial intervention, and it refers to the level of congruence between theory and implementation. So are we doing what we're saying we're doing, right? Are we following the principles, that the intervention that we're saying we're doing was founded on? And so one thing, this is actually coming from David here, but David, Paul, and I all have one thing in common in addition to our passion for this issue is that we're all musicians. And so David observed that, musical pieces sound different, even if it's the same sheet music, when they're played by different musicians. And so what I want to emphasize from this is that, you get to have your own clinical voice. Fidelity doesn't mean that you become a robot and that you can't have that voice. It's just that there's a range of styles within a certain acceptable range. And so those two things get balanced out. So I'm just going to review the items of our fidelity scale. And again, you might not be able to adhere to all of these in the setting in which you work, but I still want you to know what they are. The first is that optimally, this is provided in a group of 8 clients or less. And I know some settings groups can be quite large. 5 to 7 would be kind of the optimal size. Small is okay, but I would say things are best if they're in that 5 to 7 range. Again, we have this idea that it's 20 sessions for this version. It doesn't have to be once per week. It could be twice per week, and that could be, appropriate. The sessions last roughly an hour, and I know some places have slightly longer, some are slightly shorter, and that we usually have 2 facilitators. And the group leader follows the manual, proceeds through it in order, right? So there's a logical progression that they use the handouts and worksheet. Everyone has their own workbook. It's up to you whether or not you want people to have it to keep with them or to keep it in your clinical setting, but you would want to have people's names on their workbook so that they can get their own version. Asking people to write in it and then encouraging to read, asking people to read small sections, right? These are all techniques that we use. And then using open-ended questions to encourage people to reflect on how the material relates to their experience. We strongly encourage people to set an agenda at the beginning. And so talking about what are we going to do today? Where are we on this larger journey of addressing self-stigma and learning about ourselves? And using sort of teaching skills such as possibly self-disclosure to illustrate how a skill can be used. This could be used like in relation to cognitive restructuring, where we all can benefit from addressing negative thoughts that come up in daily life, encouraging people through praise and the small steps that they take. And then again, getting help from group members to facilitate learning. So asking if there's someone else who can relate to this, or is there somebody who can speak to a question that somebody has in the group? And it's very important that we're empathic and warm and provide hope. And so one of the things that I strongly emphasize is that believing in recovery is kind of non-negotiable. In order to do these types of interventions, we have to believe that people can get better in order to be able to talk to them about that. Using people's own language is a respectful way of using the skill. So A person may not use a clinical term to describe an experience that sounds like a clinical phenomenon. So they may talk about personal demons, but we may think that they're talking about hallucinations, but we would still want to use their language to show that we're hearing their perspective. Time management is important since we're trying to get through those 2 to 3 pages of material. So this would kind of fall on the the primary facilitator to kind of keep an eye on where we are in terms of what we want to get done. And sometimes this means that you have to use something called tactful limit setting, which could be if a person might be somewhat disorganized, where they might have difficulty reining in their train of thought. And so this might be kind of stepping in and thanking the person for their contribution, reflecting back what they said that was relevant, and kind of moving on. And so this is something that is hopefully demonstrated in the role play recording. The other thing is that using the group norms and expectations can be helpful because we talk about this in the first session. And one of the group norms is that group members should be mindful when talking to make sure they give others time to share their views. So it's something we can kind of go back to and reminding people that this was something that we discussed at the beginning and that we mutually agreed to do together. I want to note that people sometimes become distressed when they're talking about these issues related to stigma, self-stigma. And so we should be okay with that and not ignore it, but validate it, normalize it, and if possible, use some of the skills that we're learning, whether, if it's cognitive restructuring, that would be great to help people address that. But if necessary, taking time, maybe the secondary facilitator can take the time to speak to the person privately to help them get through their distress. And I also want to emphasize that even though it might seem obvious that we're going to be exploring self-stigma, there are opportunities for learning about skills in general terms or telling stories that don't relate to stigma. And so one of the things that we try to do as facilitators is bring it back to that and helping people to make those connections because people are avoidant of this for important reasons that it's difficult to talk about. When we get to the narrative enhancement part, we'll see how it's important to provide thoughtful feedback and questions for clarification and kind of model that feedback process because it's not just about writing the story, but it's about getting the feedback and getting those questions. And that allows people the opportunity to revise their story and integrate some of these different ways of thinking about themselves into it. Hopefully you'll see that more when we get to that part. Okay, so that is my introduction to the intervention. What I'm going to do now is I'm going to start talking about specific sections of it. And this is where we're going to see some of these role play demonstrations. And because we're doing pretty well on time, I think this will give us a chance. It'll give me a chance to see if there are questions after the role play. So the orientation section is the beginning of the manual. And so there's 7 pages that are intended to be covered in the first 2 sessions. And so orientation is important because people are coming in and this is their beginning of the process and we want to try to draw them in and engage them. And so, help them understand what is this? Do I like the group leaders? How do I feel about the other folks here and kind of becoming comfortable with that? And so it's important to be explicit about the group norms, but also talk about them with people, get their buy-in. I know a lot of groups will do a co-creation of the norms. We have them written down because we want it to be consistent, but regardless, we should always talk about them with people and talk about any disagreement people have with them. We also have to, of course, be good role models. And so we're asking people to come on time. We should be on time as well. And so we have these first 3 exercises that are intended to draw people in. And I think ideally you'll do at least the first one in that first group. And so exercise 1 is take a few minutes to describe yourself as you are at this point in your life. And to have maybe 1 or 2 group members share what they wrote if they're willing to. This can be quite powerful and really help people to feel some connection to other people in the group. So exercises 2 and 3, hopefully you will have a chance to do in the second meeting. And I want to note that the way we talk about mental illness and psychiatric treatment in this group is where we're not seeing it as a fact. We're seeing it as the fact is that you've been diagnosed, but we don't presume that it's a true thing. We allow people to state what they believe is true in terms of their experience of what is called mental illness. So after you do the orientation section, we move into the psychoeducation section, which is the first of our kind of active ingredients. And so we have 11 pages in the manual that are focused on this. And we have 3 main things that we're trying to focus on here. We're trying to teach people about what stigma and self-stigma are. We want to address and challenge common myths about mental illness. And we also want to talk about disclosure because that's a big kind of issue that a lot of people struggle with. We don't have a lot of time to focus on disclosure, unfortunately, but it is something that we touch on, and we do focus on advocating sort of controlled disclosure and being planful about it. So one thing that we emphasize very strongly in this section is that self-stigma is a social construction resulting from social stigma. It is not a part of the illness or the person's fault. Sometimes folks have criticized this approach as something that's kind of pathologizing, something that's due to a social oppression, essentially, and we don't want people to get that impression. What we're trying to do is help people deal with something that does affect them profoundly, but we want to make it clear that it is not their fault. It is a result of this social reality. And so we have 4 myths that we address. These are the 4 most prominent myths about people with what's called serious mental illness. We have some other versions of the manual that bring in some other myths. And so if you attend the training next week, the young adult version has some additional myths that we bring in. But so we address expectations of violence, inability to work or recover, and this idea that people are always out of touch with reality. With regard to disclosure, we do address this idea about discomfort about who do you share with, who do you not. And so we talk about the pros and cons of concealing and sharing, and we're not advocating that people start disclosing indiscriminately. We talk about controlled disclosure and kind of finding that balance. Okay, so I think we're at where we want to show that first video clip. And so running pretty well. So what it's about 10 minutes long, and this will demonstrate page 16 in the manual, in which we talk about myths. And really you only see us talk about one myth, but I hope that this part that you'll see will demonstrate the approaches that we use and the way some of these techniques that I've mentioned can be brought in. So Connor, if you can put up that first clip. So it's clip 1. So we're on page 16 at this point in the participant manual, if you can find that. And you should have it in front of you, or you should have it on your computer if you're able to. Is everybody able to find that? Okay, let me know if there's anybody who has difficulty with that. And what I'd like us to do now is engage in the process of reading and discussing as we do in every group. So is there somebody who would be interested in reading right under where it says following are a few myths or untrue ideas about mental illness, including schizophrenia, followed by the actual facts? If somebody would be willing to read myth number 1 and fact number 1. Okay, I see Melissa has her hand up, so thank you for volunteering, Melissa. And I think that would be fine. So would you be willing to read that for everybody?
Yes. So myth number 1, people with mental illness tend to be violent. Fact. So research supports that the vast majority of people with mental illness are not violent. Most people who are violent do not have a mental illness, and most people who have a mental illness are not violent. Having a mental illness does not necessarily increase the risk of violence, but rather experiencing specific symptoms such as paranoid thoughts or command auditory hallucinations, hearing voices that command to hurt others can. Like anyone in general, the risk of violence increases when people are actively abusing drugs or alcohol. Finally, it is important to note that people with mental illness are far more likely to be a victim of violence than to behave in a violent manner.
Thank you so much, Melissa, for reading that. I know there was a lot of information there. So I want to pause now and see what people's reactions or thoughts are about what Melissa just read.
I don't know. I don't buy it. I read the Post, I read newspapers every day, and it's always, person with mental illness pushes someone on subway or something like that. And like that's headlines all the time. So I either like the I just like I don't buy it.
Thanks for sharing that, Dan. And I know that what we read in the paper is one source of information that we might take to, what is and isn't accurate. Can anybody think of a reason why what is in the newspaper might not be consistent with what the facts were that we listed there?
I just wanted to ask Dan if you've ever considered that maybe the things were not the articles were not correct in stating that they had a mental illness. Sometimes we don't know if they're diagnosed with anything. We don't know what's going on. So have you ever considered that maybe that's what's going on in the papers and the articles?
Yeah, but it's like usually crazy man pushes someone on train. Like they just throw that in there. And like if it's not mental illness, why would they like use that word?
I think that you just hit on a very important point, Dan, but that the media can sometimes use words that aren't necessarily the correct words to label someone with a mental illness. The word crazy doesn't really define what is a mental illness. So it leaves things up to ambiguity and can leave things up for interpretation, just like how you might interpret it as the person might be violent. Others can interpret it like Melissa, where we don't really know what is the mental illness. Was it really a mental illness, or were they just labeling this person as crazy? So I think that just shows just how the media can be perceived very differently by different people.
Other thoughts about this? This is really important because this has a big impact on people, right? If they believe that they're a member of a group that other people would be afraid of or should be afraid of. Yes, Sherry.
So are people with mental illness violent? I still don't know.
Okay, so let's go back to what we read in the section, or what Melissa read. Do you want to review that right now for us?
Sure, I'll read that.
Mm-hmm.
You want me to read it out loud?
Yeah, read the part, where it mentions that, yeah.
Research supports that the vast majority of people with mental illness are not violent.
Right. Okay. So I think what's hard to get straight, right, is that a person with a mental illness could be violent, right? Just like a person without a mental illness could be violent, right? Thoughts about that question that Sherry asked, or what Dan brought up?
I would like to say something, though I don't know if it's really relevant or not, but I think we also need to take into account who's like saying who's crazy or not. The media, it's easy for the public to want to kind of demonize any of these like violent acts and stuff, to kind of separate people who do have mental illness from those who don't, because the public, like, they don't want like individuals like who don't have mental illness to feel like there's a chance that they might act violent. They just wanted to say like, oh, that's because they're mentally ill. Like, I would never be able to do something like that. Yeah.
That's really powerful stuff there, Kelly. So I really want to thank you so much for speaking, because yeah, you're bringing up that this gives people a sense of comfort, in a sense that I don't have that in me. That's only for somebody who has this, label or something like that. That's different from me, right?
And also, just the word crazy is something that I think can impact a lot of people, just because, like, my sister sometimes calls me crazy. And my sister, while she's not that nice to me anymore, she used to be like a friend to me, but she's been treating me differently since I was hospitalized. And she doesn't want me to meet her friends. She thinks that her friends might not like me, and that her friends might judge her for having me as a sister. But I don't think I really like her friends that much, actually. Her friends are a bit different.
Hold on there, Amanda, because I heard you say some really important stuff, and I want to make sure that we don't lose that. Is that okay?
Mm-hmm.
Yeah, so I think what you were saying is that your sister sometimes uses that really mean word about you, right? But it seems like your sister's worried about what her friends think.
Mm-hmm.
Yeah. And is that something that anybody can relate to?
Yeah, I feel the same way. My siblings always call me crazy, and it hurts my feelings a lot, and they do it in a manner where they're just kind of joking about me. So I can definitely relate to that experience.
Okay, so that's the end of our clip. So if Connor, if you can go back to the slides. Right. So I think that we have a little time to see what people's questions are about it. Right. Obviously, this was done on Zoom, and a group could be done that way, but the classic version of it, people would be sitting around a table. But we use Zoom because it facilitated the recording process. So yeah, if you have a question, you can put it in the chat now, and I'll look at that and I'll try to answer it. We have about 3 minutes that we could spend on that. Okay. I just see a comment about autism, which could be something that people could be included in a group. There's a question about group members referred to NECT or volunteer. Yeah, so it really depends on where you are and what the way things that are interventions are offered. You can offer to anybody who's interested, or you could suggest it to people who maybe you could incorporate screening for self-stigma. And so there is a question about family members. We do have a family psychoeducation version of just the psychoeducation part of NECT that I am going to talk about next week in this separate training. But so it's something that has been acknowledged as important to address as well. And let's see, one more. question about connecting people with peers. Well, yeah, I mean, I think that that's really hard in today's clinical context where there's a lot of telehealth, a lot less, you know, opportunity for people to connect with peers. And I think it's something that we need to come up with ways to do. How would we approach a group that was less comfortable participating or sharing? I think that, you know, every place is unique, and having people read things really kind of helps to draw them out. And usually there's some some group members who are much more eager. And so what you'll see in the other clips is that, you know, the folks that you see here are all playing kind of similar roles across the clips. And we make effort, the co-facilitator and I, to kind of draw out people who are a little more reserved. So every, you know, group will kind of have its own life and proceed at its own pace. Okay, so I'm gonna continue here. And again, you'll see other sections of the manual demonstrated, and that'll give you a chance to ask other questions. So now we're going to talk about the cognitive restructuring and narrative enhancement sections. And so the cognitive restructuring section has 21 pages, and they're intended to be covered in 7 weeks, or roughly 3 pages per session. And I also want to note, like, this pace is relatively slow, and it was based around our experience working with people who were long-term recipients of mental health services, let's say. And it's certainly plausible that if you're working with a younger group, that you could move through things more quickly. And as you'll see, if you do attend next week, that that version, we've shortened the number of sessions, and others have also done shorter versions with people who perhaps have less of the impairment that might slow them down in this process. So what are we trying to do here is we're trying to help people counteract these negative thoughts about the self that we believe are related to self-stigma or driven by it. And so trying to improve their self-esteem, decrease hopelessness, and give them a coping skill for dealing with stigma related social anxiety and depressed mood. And so we're kind of proceeding in 4 stages. We're teaching the connection between thoughts and feelings. Then we're teaching the connection between thoughts, feelings, and behavior. We're teaching them about how stigma and self-stigma impact thoughts, feelings, and behavior. And then we're teaching them strategies for thinking differently when confronting negative thoughts. So it's this very gradual process of learning this. Again, they may have learned this in some other interventions, but our process is very gradual and deliberative, and hopefully will help to cement maybe something they've already learned, or perhaps augment it. I want to note that this section has a lot of hands-on exercises. We want people to discuss their responses as much as they're comfortable. And this will help us to see if people are maybe misunderstanding or not, or there might be something very instructive about this response that other people can learn from. So we teach cognitive restructuring skills, and we have 3 different approaches that are very familiar probably to you, but we use our own we have our own terms that we picked because we thought they would be memorable. So there's Be a Scientist, which is akin to the traditional cognitive restructuring that you might have learned, where you're examining evidence for and against a thought. Then we have Take Your Own Advice, which is focusing on perspective taking. What would you say to a friend, or what would you want a friend to say to you? And then we have No Judgment Zone, which just focuses on the judgmental nature of the words that are used in the thought, and kind of saying, like, okay, there's something judgmental here that needs to be altered. And it could be something like lazy or stupid, or, you know, there are many other judgmental words that we can imagine. And so people are able to pick up on that. And so what we do is we just kind of teach them these approaches, and we say, pick the one that you like, that you gravitate toward. We also have section where we talk about self-talk statements that can kind of be memorized. And we sort of brought this in as maybe a backup for people who are a little more concrete and might have a harder time using some of these other approaches. But there are people who like doing both, and they like having self-talk statements that they have kind of already picked, and they also like to use one or more of these strategies as well. So we teach about it in general terms, right? This is something that you can use to deal with your train being late or being stuck in traffic or forgetting something at home that you wanted to bring. But we do want to bring it back to self-stigma whenever possible. And so as group facilitators, we're going to be, bringing that up and pointing it out, whenever we can, because that's what we're really targeting in this intervention. Emphasizing again that we don't have homework, but we encourage it. And there's some specific worksheets that are really kind of tailor-made for that, especially with the cognitive restructuring worksheet, which is at the end of the section about negative situations in your life. And so we certainly encourage you to, if you're working with people in person, making copies of that, that they can take home with them, or sending them electronic copies if you're meeting with them virtually. Okay, so the role play for this part is on page 27, where we're trying to engage people in looking at the same situation with a different thought and how that leads to different behavior. So again, it's about 10 minutes. So we'll show that, and then we'll have time to talk about it. What I want us to do today is to learn about and practice breaking down how different thoughts in the same situation can lead to different feelings. So what we are on is page 27 in your participant workbook, where it says at the top, it says same situation, different thought examples. Is everybody able to find that? Is anybody who needs help with that? Okay. So, and this is going to be helpful because this is going to show us how different thoughts lead to different feelings, and it's going to open us up to seeing how we could maybe think differently in certain situations that are upsetting to us. And all of this is affected by stigma and self-stigma, which we've already learned about. So is there somebody who'd like to volunteer to read the first thing that right underneath where it says same situation, different thought examples, up to where it has the question about how you think Steve would feel in the situation? Is there someone who'd like to read that? Okay, I see Melissa's volunteered, and thank you, Melissa. You can go ahead.
Okay, so it says, let's look at 2 examples of how the same situation can bring about different thoughts and feelings. Steve wanted to talk to someone and called a friend on the phone. His friend said that she didn't have time to talk to him. She said that she was too busy today. Steve hung up the phone and thought, she doesn't like me, nobody likes me.
Okay, thank you so much, Melissa. So what I'd like everyone to do now is to take a minute and try to respond to what is written down there below. It says, how do you think Steve would feel in this situation? And we've already learned about feelings. We've learned about feelings like sadness, fear, anger, guilt, things like that, right? So can everybody try to write down on your screen or on a piece of paper, how do you think Steve would feel in this situation? Okay, I think everyone is done writing. Okay, so if somebody would like to share what they wrote for that? Thank you for raising your hand, Melissa, and I appreciate your willingness to participate. I want to see if someone else could jump in since you just read. Is that okay?
That's okay.
Thanks. Okay, Amanda, thank you.
I think Steve would feel sad in this situation. I feel like I can relate to him sometimes because sometimes I feel like calling my mom and talking to her, and I call her and she just says that she's too busy to talk to me, and
Mm-hmm.
so she just has to hang up, and then I have to hang up. But I
Right.
feel like
Hold on there, Amanda, because I think you told us what you wrote, right? Which is that you think Steve would feel sad.
yeah.
Yes, and it sounds like something that you can relate to as well,
Mhm.
that there's times that people have hung up on you. Okay, thank you so much. And are there other people who wrote something similar to Amanda? I see Dan is nodding, Kelly is nodding. And is there anybody who wrote something different, a different emotion?
I wrote that he would feel lonely.
Lonely, okay. And that's related to being sad, certainly, right? Okay. Sherryard, did you want to say something?
I wrote that Steve would feel angry.
Mm-hmm. And that makes sense too. And why do you think he would feel angry?
Because I think she should talk to him. He needs help.
Mm-hmm. It sounds like you're angry, you know, in a sense, at this person who is being kind of unhelpful to Steve. Okay. All right. And so then let's follow that and write down our answers to the next one, which is how do you think Steve would act in this situation related to his thought that we already learned, which is she doesn't like me, nobody likes me. Okay, is everybody finished? Okay, so is there somebody who'd like to volunteer what they wrote there for how do you think Steve would act in this situation? Okay, I see Dan raised his hand and Melissa. Let's give Dan a chance first, Melissa. That's okay. And I'll ask you next. Go ahead, Dan.
Yeah, if I was Steve, like, and then, or like how Steve would act is like, I would ask why. Like, why can't she talk to her friend? Like, if it's her
Mm-hmm.
friend, she should at least tell him, like, why? Like, I'm busy, I have work or something, but I don't know. I don't like the vagueness of it.
Okay.
So I would say that Steve should just like ask why.
Instead of well, the person's already told them they don't have time, right? So you're saying Steve should sort of kind of step and say why? Why don't you have time? Is that what you're saying?
I mean, just be common courtesy to tell somebody why.
Mm-hmm. Okay. Give more explanation. Thank you. Melissa, how about you?
Yeah, I think that Steve would isolate and then want to stop bothering everybody and just kind of be by himself because he already feels sad and lonely and feels like he's a burden to everybody.
So you're seeing Steve isolating after this. Okay, so would somebody be interested in reading the next one where it says, here's a different version? And I'd like to encourage someone who hasn't read recently to read. Kelly, I know you read really well. Would you be willing to read?
Sure.
Okay, thank you.
Okay, Steve wanted to talk to someone and called a friend on the phone. His friend said that she didn't have time to talk to him. She said that she was too busy today. Steve hung up the phone and thought she usually has time to talk, so she probably really is busy, or maybe she's having a bad day. I shouldn't take it personally and can call someone else.
Okay, thank you so much. So as you probably noticed, the language was exactly the same, right? Up until it got to the point about what Steve thought, right? And so that's the point here is it's the same situation. So would people be able to write down how do you think Steve would feel in this situation? Again, keeping in mind that he just thought she usually has time to talk, so she probably really is busy, or maybe she's having a bad day. Okay, I see Melissa and Kelly seem to be done, and Sherry R is looking up as well. Is everybody finished writing? Okay, so would someone like to read what they wrote for this? Go ahead, Melissa.
So I wrote that I think Steve would feel more neutral rather than bad or sad because he actually believes that there's a reason outside of himself that she couldn't talk to him. So I think his feelings would be just more neutral or kind of like what he was feeling before.
Okay. Thanks. So what do other people think? Is there anybody who has a different prediction about how Steve would feel? So neutral. Did anybody put something similar? Okay, I see Kelly and Amanda nodding. Amanda, what did you put?
Yeah, I thought that Steve would feel better than in the last situation because instead of feeling sad or bad about himself, he might feel like maybe it's not a problem with me. Maybe this person doesn't think so badly of me, and I have another option to call somebody else. And I
Right,
could see
right.
why, yeah, that would make him feel good.
Yeah.
Yep.
And you could call someone else. So maybe there's another person you have on your list, right, to call.
And I think that's a good segue into the next portion of how do you think he's going to act in this situation, you know? So, yeah.
Go ahead.
I think that if you guys want to go ahead and take a couple minutes to write down what how you think that Steve would act in the situation, I think that would be a good time to do that.
Yeah, okay. So what are some of the responses people wrote down about how you think Steve would act in this situation? Go ahead, Shariar.
This one is always difficult for me to imagine because I don't really know Steve, so I don't know what he would do.
Great point. So it sounds like you don't know what to put, but what would you do if you were in this situation?
I would call her back to make sure she's okay.
Mm-hmm. Okay.
Steve would do.
Okay, but that's great though. In this case, we're just trying to put ourselves in Steve's shoes, right? So that's a great answer. Melissa, how about you?
Yeah, I agree with Shariar. I think that first, I think he will probably give her a call back later instead of isolating and becoming sad about it. I think he might also send a text message just encouraging, saying that, he hopes everything's okay and that, they can talk whenever they have time. So I completely agree with Shariar.
So following up with a text.
Yeah.
Okay. Great suggestion. And again, different than what we saw before, right? Where we thought that Steve would be isolating and withdrawing. Other answers for that?
I also wrote that he would send her a text, maybe after, and then maybe just call someone else to pass the time and catch up with somebody else.
Mm-hmm. Dan, you wanted to add something?
Yeah, I thought like it said what he was gonna do. Didn't he like think, oh, I'll just call someone else? So that's what I put.
Okay, well, it suggested that, right?
Mhm.
So I guess the question is he really going to follow through on that, right? Okay, so that's the end of our clip. And because we're running pretty well on time, you can put questions you have or comments in the chat, and I can try to address them. I know there was someone who had their hand up, so if you want to put what your question was in the chat, then that would be great. Okay, so I just see a comment about redirecting the emotions. We're not necessarily doing that here. We're trying to teach the people a skill, and this is just a demonstration of how it can work. But this is only one part of this overall process of teaching that, and you can see how it kind of lays out in the rest of that section of the manual. Looking to see if there are any other questions. Okay, not seeing another question, just a comment. Okay, so we'll continue on, and we'll have time at the end for general discussion, and I think we'll be able to allow people to unmute if they want to ask their questions out loud. And I know that that's faster, certainly, than writing them. So what we're going to do now is we're going to move on to the narrative enhancement part of the manual. And this is a part of the manual that our late colleague Paul Lysacker really contributed to the most, since this was very consistent with the work that he was doing in individual psychotherapy. So there's 8 pages that are devoted to this that we're supposed to cover in 7 weeks, but it really follows a different structure in a sense, which I'll explain. But what we're really looking for people to be able to do is to integrate new perspectives into the stories they tell about themselves. And so you can see this is kind of going deeper into the thoughts that people have or beliefs, maybe getting at those schemas that they have. And we also want to just emphasize that people have stories that have value, that have a right to be heard. Something that I haven't talked about is why is this a group intervention? And one of the reasons is that having an audience for your story is such an essential part of what allows it to kind of be seen as having value. So we really do believe strongly in this idea of having an audience. So if this intervention were done in an individual format, there would have to be some way found to get stories into places where people can hear them. I want to say a little bit about narrative and why it's this important mechanism. So research indicates that it's storytelling is this fundamental way that people make sense of the world in their lives. And so pretty much any piece of information or idea has to be integrated into a story in order for it to take hold. And one of the reasons why community stigma and self-stigma are so resistant to change is that we have this very powerful story that's told over and over again about mental illness, which is that it leads to this catastrophic and unrecoverable loss in life. And so it really takes time for people to get over that story and come up with a new one. There's a lot that's been written about narrative. And so this is a foundational work on it by Jerome Bruner. This is a individual therapy a book about narrative individual therapy, not focused on serious mental illness per se, but still useful. And so in this, in Michael White's approach, they talk about restoring conversations as being kind of part of what can be done in individual therapy. And I think what we're doing in NECT is similar to that. And this is a good general book about how storytelling is like this fundamental, characteristic of being a human. So why did we save this for the end? There were 2 main reasons. The first was that we really thought that group cohesiveness and comfort would be really helpful in order for this to work best, because people are quite vulnerable when they're telling these personal stories. We also felt that it would provide opportunity for integrating information from the other sections. So bringing in negative stereotypes and how they've affected people's stories and drawing attention to that, or how negative thoughts and biased thinking can come in and pointing that out as well. So we really saw this as something that could really allow for this consolidation and integration of that information. So the structure of these sessions is a little different than the other ones in that we do have some agenda setting, but then we're going to spend 15 to 20 minutes letting people write, following the prompts. And, there are individuals who might need help writing. So that's where a co-facilitator can help and maybe they can dictate it. And then we're going to spend 20 to 30 minutes asking people to volunteer, as many as we're willing, or as many as you have time to, who are willing to read their stories. And then there's this feedback process that you'll see demonstrated in the role play. And then at the very end, we would be summarizing themes. And it's so common for people to have common themes in their stories. So there's often a lot that you'll have to tie together. So there's certainly going to be a stretch of silence here when people are writing their story, and we don't include that in the recording, but it's implied. The feedback process is really important. So there's this guide to giving feedback, and without the feedback, people don't get to consider different perspectives on the story. So it's really important that we model that as facilitators, and we encourage other people to engage in that. And you'll see that demonstrated. And this may also bring in those opportunities to touch on the psychoeducation and cognitive restructuring elements that can relate to the person's story. Okay, so now we're going to do our role play demonstration from this. And so this is on a story prompt, which is stories of strength successes. So the idea here is that people have already told a few stories, but this is the first time they're seeing this prompt. And they've also been oriented toward the feedback process, but you'll see that I alert them to the guide to giving feedback on stories, which is on page 49. So why don't you go ahead and share? And so I'm not the facilitator in this clip. It's Frankie, who is the co-facilitator in the other clips, but I step in as co-facilitator.
Hi, everybody. So we started the process of telling stories about ourselves already, and we've discussed how to give people feedback on their stories back on page 49, just as a little reminder. But today we're going to do a new story that's really important. So would somebody like to read exercise 3 for us? Melissa? All right. Thank you.
Exercise 3, stories on strengths and successes. Tell a story about your life that focuses on your strengths or successes. Strengths relate to things that you found out that you could do that you may not have realized you could do until you were challenged. Successes can relate to dealing with challenges that you have faced, including mental illness, as well as other challenges you may have faced, such as substance abuse, victimization, trauma, homelessness, or health problems. Describe how you managed to overcome a challenge and what you learned about yourself in the process. If appropriate, tell about what hopes and dreams you developed as a result of this experience.
Thank you, Melissa.
So I know there was a lot of information in there. Does anybody have a question about that? About what kind of stories this could be?
I have a question. How could mental illness and substance abuse be successes and strengths? I don't understand.
Right, great question. So what we're looking for is for you to write about a situation you've had. And again, it's up to you to decide, but something where you overcame it, right? And so a lot of people don't have these challenges, and it's easy for them to sort of maybe judge someone who does. But people who've overcome them, it's often, shows a lot of inner strength to do it, or manage, Does that answer your question? So just, again, you may have gone through some of these things and not others, so it's really pick what applies to you.
All right, so how about we take a couple minutes to write down our stories, and then we can get back in a couple minutes, okay? Okay, so would anybody be willing to share what they wrote? Melissa, I appreciate your willingness to participate.
Okay, so I wrote, back a couple months ago, I would get so extremely overwhelmed with every stress or every problem, I would completely self-isolate and I would feel inadequate. I wouldn't be able to function and would quit my jobs. Ever since starting therapy and being hospitalized after an episode I had, I realized that I have it within me to deal with different types of problems and that I can learn new ways of seeing things. I never thought that I had this capability, and I'm proud of myself.
I think that's a great story. And I'm glad that you were able to recognize that you're proud of yourself and you see your strengths in what you went through. So great job. Does anybody have any feedback or any feelings or any relation to what Melissa just said?
Yeah, and you can look at that page 49 guide to getting feedback if you are not sure what kind of things you could ask.
Like, what do you think changed in you that made you go from like thinking that everything was just too much to like now feeling like it's manageable? You know, what changed?
I think having somebody that was patient with me and teaching me things that I literally didn't know before. I kind of had just one perception about how to manage stress and how to deal with it. I didn't know that I can actually take some time and look at it different ways, kind of like Steve in that example. But I think just having that that guidance and that therapy really helped me.
And I hear that you're pointing out, Melissa, that you've been using some of the cognitive restructuring skills, and maybe this happened before the group, but, it sounds like cognitive restructuring, thinking differently about things might have been one of the things that came into this story. Is that true?
Yeah, before I started therapy, I kind of, thought that everything was just not manageable. I wasn't capable. And so slowly I kind of started to think a little bit differently. And my psychiatrist was really helping me, just asking me questions. And I think that's helping. And I'm kind of getting the hang of it. It's really hard, but I'm trying.
And I also want to point out that I'm hearing that there were themes of stigma in how you looked at yourself that we've talked about, when we were talking about negative stereotypes, right? And that idea that a person with a mental illness isn't capable. And it sounds like that was some part of the way you were thinking about yourself that you found a different way to look at. Does that sound accurate?
Yeah, I was absolutely certain that I was not capable. It was just day in and day out, just me thinking that I just couldn't do something, feeling overwhelmed, and it felt like a fact that I couldn't do anything. But that's all. It wasn't a fact. It was what I was feeling that day. It was what I was thinking that day.
Are there some other things from that guide to giving feedback that you'd like to ask Melissa about her story? Someone else?
I
Maybe
just
Oh yeah, Sherry Arco.
I just want to say that I like you feel proud of yourself.
That's nice. It's great. Nice to give that positive.
Yes, Amanda.
So I saw there's one of the prompts for questions is there something the narrator is hoping for? So I guess I'm kind of curious for Melissa if there's something that like are you sort of looking to maintain, if you're looking to maintain these changes that you made in your life, how do you plan on, I guess, keeping up this like momentum with what you've done?
Great question, Amanda.
Thank you, Amanda. I think that I'm gonna try to continue seeing my psychiatrist. There's times where even that feels overwhelming and I don't want to do it. But I try my hardest to try and continue getting that therapy.
But what about something you're hoping for?
I'm hoping that I don't go back to how I was because there are days where I feel like I can't and I'm starting to get overwhelmed like before and I want to quit my job and it gets really strong. So I'm hoping that doesn't happen.
And I think that you spoke to before about having a support system and being willing to listen to different perspectives. And if you continue those mechanisms, I think that your hope will be fulfilled.
Okay, so that was our last role-playing demonstration. And so what I want to open it up to now is just general discussion and questions. So you've seen the different components of the group explained, and you've seen examples of how they could be implemented. And so I think this could be a time where people could raise hand and we could talk. But I do want to point out that this is being recorded. So if you're not comfortable appearing in the recording, you might want to just put it in the chat and then we can address it that way. Jim, did you want to say something?
Oh no, just to help facilitate.
Yeah. Okay. So so general questions.
Yeah. And you know what, Phil, I'll take the sort of privilege of facilitating this to just throw out the first one as folks maybe think or chat. So interesting how Melissa kind of in the last one floated back and connected her strengths to in some ways her therapy. It sounded like being in narrative, in the therapy in the NECT group helped her.
Right.
Is that typical in your experience with folks, or, and I guess to be clear, like prior to NECT, like helping people to connect to strengths they may have had even before they started NECT group? Is that what's more typical in terms of what you see folks sharing?
Well, I think it really depends on where people are at and that you're working with, right? Obviously, we were role playing here, and we didn't want to demonstrate, somebody who is really struggling with some of this in the role play. We're trying to present kind of an idealized version of it. But what I've seen, especially through supervising people implementing these groups, is that people really reveal parts of themselves in the narrative section that often others in the group have not heard about before, right? And so it really serves to facilitate this opening up process. And sometimes people will go back and talk about some of their earliest treatment experiences and encounters with the mental health system, and how they had a very particular perspective on it before, and then they're starting to think differently about it. So I don't know if this really gets at your question, but what I'm saying is that there seems to be this opportunity to reflect on some of these formative experiences people have had, and share with them and feel comfortable with other people asking questions about it. The other thing that often comes up is people will often talk about some of their life accomplishments prior to being diagnosed or prior to having symptoms really kind of intrude in their life in a certain way. And people will often be very surprised at some of the jobs people had or some of the ways that they were very successful before. And what this can really provide an opportunity for is to help people consider that they're still that same person, and that they could perhaps be that person again, because often people have seen that this is just something that's in the past and they can't come back to it. So that feedback process can often help bring that up, and that can be very powerful.
Yeah, and that's what I was kind of referring to, like what folks have done either before treatment began or before they were in group. What strengths they had, and sometimes it sounds like I'm hearing you say sometimes folks can reflect on lost parts of their past, but
Correct.
also kind of reminding them of those strengths that they had as well.
Well, that they're not lost, but that's the story they've been telling.
Yep.
And that they can consider an alternate perspective on it. Yeah.
And just to be, I don't want to monopolize the discussion. Please, other questions, raise a hand. If folks, does anyone have a raised hand or a question they'd like to pose to Phil?
I have a question.
Please.
I was wondering, when you start a group, is there like the opportunity that we had to have a short survey, if there was an opportunity to have some pre-narrative that you could use to compare to at the end of the sessions, like a before and after the 20 weeks? Do you know something about the participants before you get engaged with each other?
Right. Great question. So we actually have that kind of baked in a sense, because that session 1 is where we want people to do that exercise 1 that says take a few minutes and use the space below to describe yourself as you are at this point in your life. So they're doing that right at the beginning. And then we do have, in wrapping up, we ask people to do that again.
Okay.
What we then do is we say, like, take a look and see what you wrote at the beginning and see if there's a difference in how you would describe yourself. And I do recall when we were piloting this that we saw some real changes in that. And sometimes people were really surprised by some of the things that they'd written earlier on. But, you know, of course, they have it and they could be referring back to it. Or they could be telling the same type of story. So it's not necessarily going to be that type of a surprise, but at least we have that opportunity for the person to see how they describe themselves in session 1 and at the end.
And then a very short follow-up to that question is, have you experienced where, in the case of the last vignette where you showed the person said that they were proud of themselves, I have been in counseling sessions with clients that feel a victory in a session and then miss several sessions subsequent to that because they don't know what to do with the success of that. Almost, they're so used to the narrative where they had talked inwardly about failing so often that when they have a success, it's unrecognizable to them or new to them. So then they leave, or they feel victorious and then they don't feel like they need subsequent sessions. Have you experienced something like that, or have suggestions as to what to do to encourage them to finish the 20 weeks?
Well, yeah, I mean, I think that's a common issue, right? When people do have a success, getting a job, and then kind of having this all or nothing kind of view, right? With regard to some of those roles that they're interested in, and seeing that there's no space for treatment, you know, in their life after they've, you know, once they've accomplished something like that. So I guess what I would sort of say is anticipate that these things are common and talk about it, even as people are bringing up these successes. So that does happen, but we're, you know, we're working with many things that are going on in people's lives. And to the extent that we can ask questions that can prompt people to think about some of these common pitfalls, I think we can help to prevent it. So if someone was talking about a success like getting a job, we would talk about, well, how do you see mental health treatment fitting in with your ability to get this job or maintain the job? And that would be something that you could be asked about in the feedback process.
Right. Yeah, I just saw it as an opportunity that oftentimes they feel like, since we're talking about stigma, they feel like they've alleviated the stigma by finding that intrinsic success. So they're like, I'm cured, I'm fixed. You know, I no longer have to be conditioned about how I feel about the stigma of it all.
Yeah.
Thank you.
Yeah.
Thank you very much.
So I see there's a question in the chat that I think is very important. So I want to speak to it, which is about the inherent power dynamic that the facilitator has over participants. And so I think one thing that I want to note is that we certainly see that these are groups that could be co-facilitated by people with lived experience who have a peer designation. And that was actually when I first was thinking about how we'd wanted to conceptualize NECT. I was thinking that we would want to make that a requirement, but we decided to not specify that. But there are a number of instances where peer facilitators have been, the key, sort of a key player in it. And so I feel that can break down some of that power dynamic I think the other thing is just that what we're doing is we're facilitating a clinical intervention, and it's not a purely a support group in that sense. And I think that we can move away from some of that power dynamic by self-disclosing and emphasizing, our common humanity with the people who are in our groups. But that it is set up in a sense where there is a hierarchy of staff and clients. So I don't think it's something that can be completely done away with, but I think that that's something that everyone should be thinking of, and that I make a point of always trying to emphasize when I'm working with people.
And Phil, noticing that, we have time, I just put a little prompt out there for any folks who may be on this call who are peers or part of the peer community. If you have any questions for Phil or thoughts about Phil and this inclusion of folks from the peer community and what it might be like for you to implement a group or work with someone and co-facilitate it. In the meantime, Phil, no, let me go back. I don't want to monopolize any other questions that folks have. I have a couple more, but I want to make sure the audience has an opportunity. So if anyone wants to raise a hand or chat in any more questions. And I'm going to fill in the silence also and see again, folks, raise a hand. Phil, another question I had, though, in the cognitive restructuring section, as you were going through, a lot of the examples you gave are kind of, classic symptoms-based responses. What I'm wondering is, are there also examples in which self-stigma in particular becomes the thought, right? Stigmatizing thoughts. So I think you're dealing with, the examples you give are, examples of things that could happen to anyone and how, folks' internal schemas can impact those, their beliefs and thoughts and how they process that. But I'm wondering if folks have examples, or if there are examples in there around how self-stigma in particular, self-stigmatizing thoughts, i.e., I'm broken, I'm incompetent,
right. So we try to move toward that after we've kind of taught it as a general skill. And so on page 32, there's stigma in thinking, and so we kind of connect it to stigma, and then we talk about the common negative ways of thinking, often referred to as cognitive distortions, and we give examples that are sort of general and self-stigma related. So for example, for catastrophizing, or expecting the worst to happen, we give an example where a person thinks that there's no point in going to a social gathering because people are not going to like them because they have a mental illness or something like that. So we try to teach it generally, and then also in relation to stigma as well. So it's sort of it's kind of this balance between teaching it as a general skill and trying to ground it in what our focus of it in the intervention is as well. And we try to kind of seesaw between those things.
Great. I have a follow-up question in that case, Phil, but actually what I'd like to do is just looking at the time, and it looks like we're really good on time, but I want to make sure, Connor, if you could put the post survey in the chat. So I just want to make sure, because I know sometimes folks begin to leave. We want to make sure that folks have an opportunity to fill out that post survey. If you can put it in the chat now, Connor, so folks can begin to fill that out before you leave. And everyone can fill it out. So for folks who may have joined us late, we asked folks to complete a pre-survey at the very beginning. If you didn't, please still fill it out and give us our feedback on the post. But especially for folks who completed the pre-survey, if you could take a moment or make sure that before you leave today, you give us that post feedback, that would be very helpful to us. With that in mind, I wanted to go back, Phil, and ask you, when you talked about this, it's interesting because as I see in the examples, you refer to mental illness. And I know this is oftentimes, an issue of language, and you certainly frame it on that. But at the beginning, you also talked a little bit about how you try to move away from, diagnosis And of course, the general topic of mental illness and diagnosis are two very different things. But I know you talked about the importance of using people's own language to describe what they're going through. And then you also talk a little bit about kind of reframing things for folks from what is true about them. Could you say a little bit more about that and how, because I'm hearing a sort of more stigmatizing, sort of normalizing way of addressing mental illness and then the language throughout around mental illness. So could you say a little bit more about that and how that plays out for folks in terms of being able to, sort of normalize their experiences?
Right. So yeah, we want to allow them the opportunity to define their experiences the way they do, but what we sort of treat as the fact is that they've been diagnosed, right? That's why they're here and wherever that is. And they may disagree with it, and they may disagree with kind of the official version of that story. And they may also hear people in the group talking about mental illness as a fact, and they may disagree with how those other group members discuss it. And so we as facilitators want to kind of stay neutral as much as possible on that, and allow people to have those different perspectives in the room. And there is kind of this balance around that. I do want to point out that we have sometimes this means that you have somewhat long and awkward sentences where you say like the mental illness, what you've been diagnosed with, or your experience with mental health treatment or something like that. And when I remember when the Swedish translation happened, I met with some of the folks who were involved in the groups, and they said like, "Oh, we love this, but why does it say your mental illness?" And I pointed out that was a mistranslation and a glossing over of some of that careful language. So it is really important to us to not have it have that tone, and that's something that the facilitator has to kind of be in on and sort of maintain that throughout in the things that they say. So it is a balance between those two things, but we are working with people who are getting treatment, and that is a reality that we want to acknowledge, and we don't want there to be any sense that that's a bad thing, which would be reinforcing stigma and these other negative stereotypes as well. But we want to be aware that some people in the room might be have very strong feelings that it's not correct in their case.
Right.
So I just want to point out that I am available for questions by email. And I know some folks might want to check in with me about other things. So I want to make sure you have my email address and you feel free to reach out about that. And there's something else is there another slide here that we should go to, Jim?
Yes, so I can cover a few more, but I just want to make sure if there are any last questions because we do still have a little time. Any final questions for Dr. Llanos? Okay, and feel free, because I said we'll have we still have a few moments left, but a few things, upcoming events, and as Phil mentioned, and I think Phil, if you'd like, you can also give a little preview. So just as a reminder to folks, well, these are a few of our upcoming events. So please feel free to go to our CTAC website and sign up for this. We're doing a piece on people-centered planning, advancing Southeast Asian American mental health, cultural curiosity for youth peer advocates, and then the follow-up to this training, narrative enhancement and cognitive therapy, adaptations for youth and caregivers impacted from mental health. So I saw some questions come up about that. And then optimizing treatment for youth anxiety and related disorders over telehealth. So I also want to take this opportunity, Phil, for folks in the audience to get a bit of a preview, or if you can talk a little bit about the adaptations for youth and caregivers that obviously you're going to go more deeply into in the next training.
Yeah, and I do want to say there, there will be repetition from today, so it may not be somebody might not want to attend both because I'd be talking about the general principles, but some of the adaptations we've made have been based on qualitative research that we've done with youth and family members. We were specifically focused on people who'd experienced the first episode of psychosis. But there's other adaptations that have been made with youth with bipolar disorder and some other clinical conditions. So a lot of it has to do with changing the language and the examples and using examples that speak to youth experience. Obviously, there's a lot of focus on social media and kind of the online realm in the youth experience. So that's brought in. And some, incorporating video clips that can also help to give people a sense of what stories could be like. So that's something that we also brought in. And then the family component is really because we heard resoundingly from the youth and family members that they thought that it would be really helpful for family members or guardians to be on the same page with the ones that they are caring for and that they love, and really learn about stigma and self-stigma. Of course, we wanted it to be much shorter. We know that they have limited time and availability. So the idea is that it would be concurrently offered, maybe once per month meeting, and that it would allow them to learn about stigma and self-stigma as their loved one is going through the NECT adapted NECT group as well. So that's kind of the idea there. And it's possible that it could be offered as a standalone intervention as well. But that's what we developed and what I'll talk about next week.
Yeah. Well, and just another reminder to say that, again, just because we have some time, I also wanted to say, if you can say a little bit more, I know you've mentioned to us in our preparations for this that that although it works best as a group model, can you say a little bit about the use of this or parts of it, or how you might integrate it if group is not possible, or if you're working individually with folks? I wanted to know if you can mention that a little bit. And I know it's not ideal, but yeah.
Yeah, I mean, obviously, we're making it available, and we people are free to use what they want to use, as they see fit. And if they think that some of these worksheets would be, they want to copy something from the manual and use it as a worksheet in individual therapy, that's totally fine. And if they want to try to do this individually with somebody, that's also fine. I think that it's going to work best in group because of the audience, because of the cohesiveness and support that people will get in the journey. And also because when you're talking about some of these concepts in a group, you can create a little bit of distance. The person doesn't feel like it has to be about them, and that can allow them to be a little more open to hearing about things that might be difficult or might not fit in with some of the ideas that they're used to having. So I do believe that it can work best, but I know, groups, it's been very challenging to do groups since the pandemic. And that might be something that's difficult for folks to do. So I do think, there are opportunities for adapting individually. I do want to note that it hasn't been studied in that way. So we can't say that it's evidence-based individually because it hasn't been studied as an individual intervention. But yeah, there are opportunities to try it that way. And I think that is totally fine.
And Phil, again, I feel like I'm just sort of monopolizing, but again, unless there's other questions, one last question, and I think this is something that you touched on, and I don't know if you mentioned it with regards to the youth version, but if you could just say a little bit too about other stigmatizing aspects of the identity, so their young people's identity or people's identity, right? So for people of color, people in the LGBTQ community, as you think about this, is there space to also talk about ways in which, and if I do believe, I know there's some discussion, and I don't know if it's in this youth version, but oftentimes talking about mental illness with young people and other aspects of their social identity and how that intersects with stigmatizing beliefs. I don't know if you can talk a little bit about that. And sorry to drop that kind of maybe too big.
No,
but yeah.
It's very important to ground what you're discussing in those other experiences. Interestingly, this past Monday in the NECT Global meeting, one of the presenters talked about having targeted dual stigma groups focused on people who identify as LGBTQ and having a mental illness. And one of the questions was, oh, is there an adaptation of the manual for this? And there wasn't any change in the manual. It was all in the facilitation. So this is one of those things where, as a facilitator, you can bring in those kinds of prompts around other stigmatized experiences people have had related to race, ethnicity, sexual minority status, health conditions such as HIV, and the like, and bring that in considering how these multiple forms of stigma and discrimination have affected them. And that might come up certainly in the themes that are told in the story that they tell in the narrative enhancement part.
Great. Okay, folks. Well, we are at time, and Phil, thank you for that. And I think just want to remind folks again, Phil will be doing this training. You can sign up again if you want to see some of the adaptations for youth, or pass it on to colleagues that you know that work with young people and their family members. Just a couple of words. There's some information here about getting CEs for this. As mentioned previously, you will get an email. Your CEs will be dependent on your participation and the amount of time spent on this webinar today, on this training today. So you'll get an email for that, and you'll get all of the, as you get that email, you'll get the instructions for how to receive your CEs. And again, just to clarify, CEs are available for LMSWs, LCSWs, and LMHCs. And these are just some of the instructions that are in there. These slides will be available. Just a reminder again, these slides, the recording of this training, the materials are already uploaded for this training, are all going to be available on our CTAC website within 2 to 3 days. So you can go back and review information that you haven't already and look at these instructions for getting your CEs. Again, I want to thank you all for participating today and being a part of this training. And I want to thank our wonderful presenter, Dr. Phil Llanos, for a great training. And we look forward to having him back again in a week to do it again. Take care, everyone, and have a great rest of your day.
Thanks a lot. Appreciate the opportunity to do this. Thanks so much.
Take care.